All right. So welcome everybody to the live National Centre for Mental Health Research Translation Ready, Set, Translate session today. I'm Priscilla Ennals and I'm the Senior Manager of Research for NEMI National. So welcome everybody. Just want to start by acknowledgement of country. I just want to acknowledge the Wurundjeri people of the Kulin Nation, who are the traditional custodians of the land where I am in Melbourne today, and I want to pay my respects to elders both past and present, and to extend that respect to any Indigenous people who are present today who might be tuning in online. And if people want to acknowledge country they're on, please feel free to do that in the chat. It's always nice to see all the lands people are on. Also want to pay recognition to people with lived experience, recognise that lived experience within the room today, and that we speak honourably and respectfully about ongoing emotional distress, experiences of trauma and mental health, and the work of caring and experiences of care within this context. So today we're here for the Ready, Set, Translate series, and we're very lucky to have Jenni Campbell joining us. I just want to go on to tell you a little bit about the network that's hosting the session today. Ooh, sorry about my dogs. It's the Implementation and Translation Network as part of the Alive Centre. And what this network is about is we're really focused on research translation. It's a community of practice addressing questions of implementability, scalability and transferability at scale, delivery of mental health across primary care and community settings. Very uncomplex set of words there. So the network's been meeting together and wrangling what that means for us. And I think we're really making some progress now. And you'll start to see some of the outputs from the network. So some of the detail that you'll be able to read about the work that this network and other networks are doing across the centre is available in the update. And I think Caroline's, she's just dropped it into the chat there. So if you missed that in any email updates, you can have a look at the update. So this slide outlines a few of the projects that are happening. So across the centre, and it's complex and there's a lot going on. So I'm not going to talk about it in detail at all, but if you want to read about those projects, check out that update and you'll find it all in there. So this network is co-led by myself and Caroline Johnson. So we're working with a group of amazing expertise from around the country on implementation and translation research. I think we're learning a lot from each other, and we're starting to make sense of it all. So it's a real pleasure to have you all here today and to host Jenni, who's going to be talking with us. So we do want to, if people are interested in asking questions, please feel free to drop them in the chat along the way, or that we'll make sure that there's time at the end, and Jenni's really open to responding to any questions and to seeing what people are most interested in focusing on. So to introduce Jenni, Jenni Campbell is providing consultancy services to the Australian Department of Health and Aged Care, delivering the National Initial Assessment and Referral for Mental Health Care Initiative. Jenni recently concluded a 4-year ministerial appointment as Chair of New South Wales Mental Health Commission Advisory Council, and she's also a board member of the Perinatal Anxiety and Depression Australia, PANDA, qualifications in social work and health service management. So thank you very much, Jenni. We'll hand it over to you and we'll check back in at the end.
Thanks so much, Priscilla. Hi, everyone. It's lovely to be welcomed here today. I'm joining you from Wurundjeri Nation. So our very full 3 rivers are Murrumbidgee, Lachlan and Murray. So I'm based in the southern pocket of New South Wales, and I'd like to recognise the land that I'm joining from today. I am so thrilled to see so many familiar faces, but that makes me a little nervous. And hi, Eugene, it's been a while. I'm a little nervous that might mean that a few of you already know a lot about IAR. So hopefully for those of you who are already feeling familiar with the initial assessment and referral project that is being led by the Australian Government Department of Health, if you already feel quite familiar, hopefully you'll still learn something, but at the very least have an opportunity to ask lots of questions and have a discussion. And I certainly have tried to pitch my presentation today for those of you who are in the room who aren't too familiar with IAR, or perhaps not familiar with its development journey and where we're going next with the project. So that's what my presentation will focus on today. So for those of you who have been around a while in mental health care, you'll know that in 2015, the National Mental Health Commission recommended that we adopt a stepped care approach to planning, design and delivery of mental health services in Australia, with a particular focus on primary mental health care and community mental health care. And we know, and making sure we're all on the same page from the get-go, we know that there are two really critical aims with a stepped care approach. The first is that we understand enough about an individual, so an individual being the person who is seeking help from mental health services, so that we react with an assessment that helps us understand enough about that person that we can make a confident recommendation to them about a service type and intensity that's likely to be compatible with their treatment needs and recovery goals. And in doing so, we know from the work that we did around literature reviews and evidence base and bringing forward experts into an expert advisory group, including people with lived experience, that we needed to push beyond that myopic focus on symptoms and diagnosis and risk, and out into other domains that we know and understand are important when it comes to making decisions about intensity of the response that a person might require. So that's objective one. The second core objective in a stepped care approach is that we sufficiently monitor how a person is responding to the resource or service that we've recommended. In doing so, we're looking for signs of benefit. You know, if a person is responding well to the resource or the service, we might look to continue as is and slowly decrease intensity. But of course, we want to be on the lookout for any signals that might indicate no progress, or perhaps even a worsening of experience for the person. So worsened symptoms, heightened distress, impaired functioning. So IAR, being the initial assessment and referral guidance and the decision support tool that accompanies the guidance, are largely focused on that first objective, providing guidance into Australian primary mental health care systems as to what it is we need to be looking for when we're estimating someone's treatment need. I will start sharing some slides now, just so that I can talk to you more formally about the objectives of IAR. And so our first is one that I've touched on already, supported by literature reviews and environmental scans and an expert advisory group that's met over 5 years now. We have designed what we call the 8-domain assessment framework. So these are 8 holistic assessment domains or windows that we ask people to look through when understanding a person's likely treatment needs. These 8 domains and their rating guides include information and detail that helps amplify key signals that are critical for decision making, and in particular, really critical for helping inform decisions about whether primary mental health care and community mental health care is appropriate, or whether the person might require support to access specialist and acute services. As I mentioned, we are looking to respond to a person's treatment needs based on intensity. And it was really important as we set out on this IAR journey nationally that we began to describe the steps of care in the Australian context. We hadn't done that in a nationally consistent way. And so the 5 levels of care that I'll show you in a moment have their origins in this project. That was one of the early pieces we had to undertake. Some of you might even be familiar with some of those graphics around stepped care, where at one end you have well well population, and then you have mild mental illness and moderate mental illness. And that's not stepped care. That is a graphic depiction of illness prevalence in a population. That's a categorization of people based on severity. Stepped care is not about categorizing people, rather categorizing services and types of interventions based on their intensity. And so the levels of care are about a continuum of resource and service intensity rather than a continuum of illness prevalence in community. So whilst I think many of us talk about the 5 levels of care, certainly I was in Central and Eastern Sydney PHN region on the weekend, and hello, Jenni Smith, it's lovely to see you here too. And people were talking about level 3 and level 4 like it was part of the lexicon now. And yet it wasn't that long ago when we were still designing these levels of care. So that's helpful in terms of service planning as well. And for those of you who are a bit more into research, the University of Queensland assisted us to dive into the National Mental Health Services Planning Framework to estimate the associated treatment need at each level of care using the 178 or thereabouts care profiles of the planning framework. So there's been a lot that's gone into that work on its own. I mentioned already the IAR guidance. So that is this 80-page PDF that takes you through, introduction, setting the scene around our mental health sector, presenting the domains and the rating guides, and explaining the levels of care. We have also digitized the guidance into a digital decision support tool. And so therefore, when people pick up the guidance, it's called the Initial Assessment and Referral Guidance. It sets forth an 8-domain framework for an assessment, but it isn't technically a new assessment tool. So you're not going to open the guidance and find a new script or a new measure to use in a clinical interview with an individual or their family. Rather, it is a framework that guides your assessment and a decision support tool that recommends a level of care. As I introduced the objectives of stepped care, one of the things that I didn't say, which I normally do on entry, is that I was, as mentioned by Priscilla, I'm a social worker by trade, and as a mental health clinician, was never all that convinced about the stepped care argument from an economic rationalisation point of view. And this early rhetoric in Australia was certainly around, that we have finite resources, we need to manage them carefully, and we need to... sorry, I'm just hearing a bit of feedback on the line. I wonder if people can check their mute. And so it was really important, even for me, when I was asked to come into this program, to understand, well, hang on, where's the person at the centre of stepped care? We've talked now for a while about, finite resources and managing them beautifully as gatekeepers, but I would much prefer more funding, a bigger workforce. But stepped care at its heart is about minimising the risks that arise through underservicing. And again, as practitioners working in mental health care, that's something that we're striving to do a lot, because we absolutely appreciate that there's a risk of poor outcomes for people if we underestimate their treatment needs. We may have insufficient therapeutic intervention that's going to lead that person to experience gain or benefit. They may even experience an increase in risk of harm. What we don't necessarily talk about as much is the concern around overservicing. And so, yes, we know that overservicing leads to us using finite resources in an irresponsible way. We've got that, right? The economists are really concerned about that. But there's also good literature that tells us that where the burden of an intervention exceeds the value a person is deriving from the care, that is where we get dropout from care and poor care experience. So I like to always reset around the person-centred objectives of stepped care. Importantly, if you were to choose to use the guidance or the decision support tool, it is really important that you keep in mind it is an aid, it is a decision support tool, and therefore it doesn't replace your judgment as a clinician or practitioner, nor does it compromise the importance of an individual, so a consumer, being involved in and an active partner in their healthcare. And so we've trained about 5,000 people in the use of the IAR tool now. And we always finish our training talking about care type, care appropriateness, and supported decision-making. And we provide our training participants with additional resources around supported decision-making in stepped care as well. Please do think about any questions that you might have and adding those to the chat box in case the talk goes for a little too long and you forget them all by the time we wrap up for a Q&A. But these are our 8 initial assessment domains. I'm not going to dive into each of them. We run national training weekly, so you're definitely welcome to come along. It's free training. It's online, so you're welcome to come along and learn more about the domains and their rating guides. But as I mentioned before, IAR really pushed us beyond diagnosis and into 8 other domains that we know are really important. And when I talk about diagnosis, it is important to acknowledge that these domains and the levels of care are transdiagnostic. And so whilst a person might have a diagnosis, it is not what we're anchoring decision-making around. The tool helps us respond to a person's needs at a point in time based on what's been typical for the person over the last 30 days and taking into account any sudden or recent changes or deterioration. And yes, having a diagnosis might help us begin to personalize the response or the resource a person might need, but it is not going to have any influence on the intensity that the tool recommends. And that has been largely celebrated, but it does mean that for those who do have a diagnosis, there is that extra step of thinking, well, are there any diagnostic specific services or resources that I might need to activate for this person? Within the 8 domains, there is a rating scale that allows the clinician or practitioner using the tool to estimate the extent of the impact associated with the domain. So is the person experiencing mild, moderate, severe, or very severe symptoms? Are they at no through to very high risk of harm, etc.? So each rating on each domain is captured within a logic. That logic has 496,000 possible rating combinations that leads the tool to recommend one of the 5 levels of care. So it is not some system of adding up and seeing if the person crosses some arbitrary line in the sand that qualifies or doesn't qualify them for a level of care. And the logic that underpins the tool is in the guidance. So there's no smoke and mirrors, it's fully available. People can scrutinize the logic and understand how it works. And I've included a copy of this logic in the slide pack as well that is available for those who like flowcharts. So these are our 5 levels of care. And I mentioned, of course, that like our domains, our levels of care are transdiagnostic. I'll go into explain a little bit more about that as it relates to the levels of care in a moment. But firstly, as you can see, there are 5 levels of care. They're differentiated based on the intensity of the resource or service that's associated with or available at each level of care. Level 1 is self-management, and you can see here the Australian population estimate of the treatment need associated with this level, so 6.4 million people, which is startling, especially for people in mental health and community care services, because if this level of care is functioning as it should be highly visible, easily accessible, free or low cost, and not require a formal referral. And so therefore, more likely that people in community are making their own way there. There is still absolutely a role and function for navigational and wayfinding assistance to locate evidence-based resources that are likely to benefit the person, and GPs and others, including school teachers in the education system, have a really important role with that. But it's not likely that we're going to see in the mental health sector very many of these people until they've tried self-management and are looking for something more. So we are living in 2022, and it is very likely that digital interventions are the predominant way people will access a self-management resource, and platforms like Head to Health have certainly assisted people finding evidence-based resources, but it also includes things like podcasts, printed resources, attending an education event in the community. At level 2, we have low intensity interventions. So these are services that can be accessed quickly, easily, don't require a formal referral, but do typically involve some form of personalised assessment, some contact with a clinician or with clinician assistance. One of the most well-known low-intensity models in the Australian context is New Access through Beyond Blue, but there are certainly a range of evidence-based interventions that various levels of government commission or fund, including local council and primary health networks. And again, thinking about the intensity, we're thinking about few or short sessions, and the overall duration of the course of service is likely to be brief. At level 3, we have moderate intensity interventions. So structured, reasonably frequent, longer in duration, and focused psychological strategies through Medicare or a psychological intervention commissioned by a primary health network is what we would typically associate with level 3 care, more likely to require a formal or provisional referral. And IAR does not recommend the number of sessions a person might need. That is a care planning decision that's further on in the flow. So IAR is not going to go into the detail about how many sessions a person is likely to need. High intensity level 4 is a really interesting level of care. So as you can see from the description, level 4 typically involves periods of intensive support. It may still be that there's a psychological intervention at the core or the heart of that response, but it is likely to include clinical care coordination, some specialist liaison or consultation, and other services. Head to Health centres, previously Head to Help in Victoria, have been funded to straddle level 3 and level 4 care. There are some other examples of level 4 services, such as a service that's been set up to support people with disordered eating, or an early psychosis service may have the capabilities associated with level 4. But if for many of you, and whenever we talk about level 4, the most common reaction is, oh, wow, that sounds great. It'd be really nice if my community had anything that even looked like level 4. Here in Wagga, we don't have a Head to Health service yet. So if I'm a practitioner using this tool in Wagga, I would need to be making multiple referrals and bundling up, packaging up a care team in order to get the intensity that's indicated by level 4. And that absolutely is the reality for many communities. Even in metro and urban areas, there might be very high demand for these high intensity services, and the consequence is the same. Finally, level 5. So these are acute and specialist services provided by our state territory colleagues. They include anything from, emergency department mental health assistance, acute admitted assistance, subacute, assertive outreach teams. So we lump all of it into level 5. And the reason we do that is because the IAR tool will signal to the user that a level 5 referral is likely to be indicated, but it is then up to the state and territory partners to react and undertake a triage that will determine the urgency and the nature of the response. One of the reasons it's been so important for the Commonwealth Government to negotiate arrangements with the state and territories is because of that intricate and important interface between primary mental health care and specialist and acute care. So there is reference to the IAR guidance and decision support tool in all the state territory bilateral agreements with the Commonwealth. It doesn't mean the impact of those agreements will be felt the same across the country. Some state governments have committed to looking to explore only the implementation and use of IAR, so it's a commitment to explore. Other states have committed to use the IAR tool, but we're not sure in what context yet. Again, I know in Victoria, a lot of the funding models that are coming out of the Victorian government are referencing IAR. Certainly our sincere hope that we're able to create a shared language around treatment need between the community and primary care environment and our specialist and acute mental health service partners. So I'm going to just show you around the IAR tool. I'm not going to do the full I guess, concierge navigated tour that I would normally do, but just point out a couple of things. I'm also going to just drop the link to the tool in the chat box for those who are interested in having a look yourself. So I mentioned that there are, nearly 500,000 rating combinations that inform the tool's recommendation. It therefore was really important that we digitized the tool. This tool sits on a standalone website. The vendor is a company called Logically, which many of you will know. They are one of the Commonwealth Government's preferred vendors. Before I show you around this tool, though, one of the things that we set out to do with this initiative, and this is why it's being so carefully led by the Department of Health, rather than a big consultancy firm or, sector-based collaborative. It is owned by the Australian Government Department of Health and Aged Care because we didn't want to see this commercialised, and we wanted to democratise the work as much as we could. So the test data set is completely free of charge, and a licence is available for anyone who wants to build it into their own client information management systems. The training that we provide is free of charge and runs at least weekly at the national level. So for those of you who do want more information about the data sets and the test library and the tech that sits behind it, always happy to chat. So you'll see I don't need a login or password, but I do need to accept the terms of use. And the headline term of use is that this is not a replacement for my clinical judgment. I'm then able to see all of our 8 domains. And once I've inputted a rating on each of the 8 domains, the level of care here will auto-populate, and it will flash yellow to let me know that the recommendation has been produced. I would never usually use the tool by just selecting a rating from the drop-down box without first reading the rating guide. And our rating guides provide us with a reminder of what this domain is asking us to focus on, because we like to say that the domain headings are very broad, but the focus of each domain is quite narrow. It is designed to be an initial assessment rather than a comprehensive assessment for the purposes of treatment planning. The role of these descriptors is to provide additional detail to otherwise vague, ambiguous, and subjective terms that were common in stepped care models prior to this particular project. So I will use these descriptors to help me determine if there is a mild impact on functioning for the person. Sorry, I'm getting a Zoom toolbar that's popping up every time I try to close this window. So once I've reviewed the rating guide, I then go in and put in my ratings. I'm just going to rate all 8 domains randomly so we can go through to the next step. So we'll see that's flashed yellow now. The level of care has been generated. If I make a change to a domain rating, it may not impact the level of care, and therefore there will be no change. But if I make a change that does impact the level of care, it will flash yellow again, because we know that practitioners use this tool in fairly dynamic ways. You're thinking about your assessment discussion with the person that you're working with. You might have been talking to others like carers and families or a school teacher. You might be rethinking information. So it's really important that the tool stays up to date with your dynamic approach to its use. I can then read more about the level of care here. And the slide that I showed you was a very brief summary of much more detailed descriptions of the levels of care. And at most of the levels, we have core clinical services. So this is what we would call the bottom of the scope of level 3. and other clinical interventions, which we refer to as the top of the scope, because even within each level, of course, people are going to have variable needs. I'm then able to generate a report, and this is really important for those people who are using the tool when it's not embedded in with your own client information management system or online referral tool. And it allows me to, I'm not going to show you today, but it allows me to document my use of the tool. It allows me to add some commentary to my ratings or to my decision about a level of care. But most importantly, it allows me to nominate a practitioner determined level of care. And that is because it's my practitioner determined level of care that determines what happens next. So if I do not agree with the level of care, or perhaps the person I'm working with isn't ready for that level of care, I absolutely can select a lower or higher level of care than the tool is indicating. You are all able to provide feedback at any time using this link here. Any feedback about the technology comes through to the department and their vendor, logically. And the fact that we have this generate report function at all is because of feedback we receive from users using this link. So it's really important. If your feedback is practice or lived experience-based feedback, it is also really important. It is reviewed by our expert advisory group, and we are able to take action on the feedback we receive from the field. So it's one of our quality improvement, pathways. You can access the most up-to-date version of the guidance by clicking on this link. And as you can see, we're up to version 105 already. Internationally, we are, pioneering this sort of work. And we were having that conversation at our expert advisory group yesterday as it related to the evaluation. And so it has always been really important to us that we have a really rigorous approach to continuous quality improvement and feedback from the field. I want to move on to talking about the what's next for IAR and the bigger picture in terms of the national policy. But before I do that, I am just going to check the chat box and answer a couple of questions, if that's okay. So Eugene, how is the child and adolescent design coming along, and are there more plans for a self-assessment tool? Yes, I'm going to talk about that in a minute. Perfect. Tricia, yes, Priscilla was perfect. We've trained 5,000 so far. And as you'll hear, and look, that is another really important quality improvement pathway for us, because we do have about 10% of those training participants go on to complete surveys for us in terms of their impression of the tool. We also know that the number of people engaged in the IAR training will rapidly increase because of the investment in each PHN region in a training and support officer, who are all being trained in being able to train in the tool. So they're going through a train the trainer program, and it's great to see a couple of them online actually. Hey, Paul. Are we getting any feedback from state territory mental health services? Yeah, it's been really important to me, I suppose, right the way along in this project, that there isn't a perception of a mandate that's associated with IAR. So there are definitely some targets around training, and there are definitely some service models that are coming out really clearly saying, look, we'd like you to use IAR. But I've had lots of conversations with state territory mental health services over these last 5 years, including from local health districts in New South Wales through to chief psychiatrists in South Australia. So it's great to have that sort of level of engagement and supporting people to explore, to develop their understanding about IAR. As a result, though, of the last few years of effort, we certainly have had, one state government education department come online very heavily with IAR. We've had most of the local hospital networks in South Australia begin training in the use of the tool and exploring the use. In fact, North Adelaide Local Hospital Network are about to release a research paper on their experience of using the tool and its use in that environment, in a specialist and acute environment. And then, of course, we have other state territory partners that are, less enthusiastic, less resourced, not ready, recovering from a pandemic or bushfires or floods, but certainly lots of conversations, lots of education. And I'm really pleased we're in that space. Great questions. Okay, so I'm going to go now so please do keep thinking about questions, because we have at least 15 minutes set aside for questions and answers at the end. I wanted to make sure that I'm sharing with you, especially because I know, the important work that's being done by the centre is absolutely, lived experience led, based, and in a stepped care approach to mental health services, sometimes it can be really difficult to find where is the consumer's voice in stepped care. So if the tool, for instance, is recommending a level of care that your clinical or practitioner judgment concords with, what say does the person have in that? So we, as I said, we like to make sure, and this is absolutely based on the advice and wisdom of the lived experience representatives involved in all of our working groups and our expert advisory group, that we really wanted to take the opportunity to promote supported decision making, and that IAR is a really useful decision aid, must still protect and preserve the person's right to express a choice and preference in their own mental health care. So we always encourage a choice within the step of care where possible, but equally where a person is not willing to accept the intensity that's indicated, absolutely acknowledging their right to start at a lower level of care and thinking about what that means in terms of us progress monitoring, checking in with that person, communicating with them, and agreeing to try other options with time. If someone wants a higher intensity care than is indicated, finding out the why. They had a great experience of care at that level in the past? We train people using a scenario or a vignette, and that vignette's about William. Now, William is a gentleman with schizophrenia who the tool usually indicates needs a level 3 or level 4 response, but William's got an established relationship and an exceptional therapeutic alliance with the community mental health team and an ongoing relationship with the psychiatrist. So making sure that perspective is heard as part of the decision making, and hearing William's views on the sorts of resources or services that he would find most valuable is a really important learning conversation for many of the training participants. And we also do send out additional documents, including one that was co-authored by the University of Melbourne around supported decision-making in mental health care. We do talk about the care preferences of a person as well. So the tool's making a recommendation about service, resource or service intensity, but we still need to be really mindful of a person's care preferences and also the type of care. So at each level of care, we still have a responsibility as users to think, is there a culturally appropriate service that's available at this level of care? Is there an age appropriate service? And again, training is really focused on making sure people are using the tool, but not overlooking the importance of personalising care. So I'm going to quickly share with you now the version development process, and including a response to Eugene's question about the next versions to come. So as I mentioned, we've been working on this initiative for about 5 years now, which is an incredibly long time for a government-led piece of work. That's included 20 meetings of an expert advisory group with a really consistent membership over those 5 years. As I mentioned, people with lived experience, both consumer lived experience and carer lived experience. So we'll have 4 people with lived experience involved in our expert advisory group, as well as representatives from all of the professional colleges, such as the Royal Australian College of GPs and the Australian Association of Social Workers. And because we did a great literature review. In fact, we've done a couple now, as you can see. But because we are, as I said, internationally sort of pioneering this work, it was really important for us to bring to the table a couple of our universities, including the University of Melbourne and the University of Queensland, and sector leaders in stepped care like Black Dog Institute and MindSpot. We've then had 12 working group meetings focused on developing adaptations across the lifespan, so for children, adolescents, and older adults. And we do all of this development work under the umbrella of a version development framework. And that's so that as this work makes its way out to you in the not too distant future. So we hope by the end of the year, the child, adolescent, and older adult versions will be released for use, and there will be an evaluation that's funded by the department. So it won't be a limited release trial, it will be a broad release. It's so that as they make their way out to you, there's a consistent look, feel, and operation. So you will still use an online decision support tool. You'll indicate an age attribute. So am I working with a child, an adolescent, an adult, or an older adult? And then those rating guides that are so important in the tool, they will automatically update based on the age you've indicated on entry to the tool. We have done an implementation review already, and that was University of Melbourne were the custodians of that in partnership with the University of Queensland. We've done 4 nationwide environmental scans, which have involved hour-long interviews with PHNs and other partners at the regional level. 3 public consultations with 78 consultation responses. There has been a formal review of IAR in the Head to Health environment as well, which we are anxiously awaiting the release of, but I've had early access to the evaluation report, which is very inspiring. I mentioned already that the North Adelaide Local Hospital Network is coming forth with some research soon too, which will certainly help our state and territory colleagues grapple with the relevance of this work to their environment. And as I mentioned, we've got that training program underway and received some great feedback through the surveys as well. So last year, the Commonwealth announced an investment of $34 million in supporting implementation of and meaningful use of the tool. And so across the primary health networks, there are now 31 TSOs or training and support officers whose role it is to assist general practitioners and other organisations to understand and implement IAR. They will always be supported by a national training framework as well, particularly important for those stakeholders or organisations that don't identify with a particular PHM but might have a national or state-based or other role. There is that target of training 20,000 GPs in understanding and using the tool. The ambition behind that was to bring deliberation to decision-making as early as possible in a person's care journey, to avoid the number of times a person might bounce around in our system because someone hasn't taken the time to appropriately estimate their resource or service needs. So GPs are, of course, a huge, huge stakeholder, and that is absolutely work underway. IAR is being implemented in the national phone line, you know, the Head to Health phone line that everyone talks about, but no one's really quite sure what it's all looking like, or maybe that's just me. The Head to Health centres and other Commonwealth funded mental health services are expected to begin using the tool from the budget announcement and beyond. So it's not that everyone will come online on the 1st of October. There is no set date. It is expected that it'll be progressive implementation. Those lifespan adaptations will be available, we think, by the end of the year, but that's in the department's hands at the moment. We already know that the code library and the test data set is available for those who do want to build it into their systems, but the National Digital Health Agency is also working closely with the branch responsible for IAR to build the tool into general practice and other key information communication technology systems at the national level. The department will also procure an evaluation that will run through till 2025, which I'm exceptionally excited about. I think we've touched on this except for this final point, and I know, Vicky, you might have had some other questions about this, but we started with development across the lifespan. The department is now looking to engage a cultural lead who will lead the development of an adaptation for First Nations people, and it will be based on the expertise and the advice of the working group that will sit around this work. That might not be a new adaptation, but a comprehensive cultural review of the adaptations across the lifespan. If we have a new adaptation, it will be based on the advice of that working group and cultural lead. That is expected to be about a 12-month journey from start to finish in terms of the adaptation, and then it will take a little longer to get that out into the world. And then we'll begin work on, again, looking at an adaptation for culturally and linguistically diverse groups, or a comprehensive cultural review of the adaptations that exist already. I just wanted to make sure this slide stays up. Part of my job is just to be around, answer emails, answer phone calls.